Hey everyone, it's Dr. Namani and Dr. Louis back again today with another episode of the Athlete Spine, and we're really excited to have Dr. Peter Derman back on today. We've had him on previously. He is a endoscopic spine surgeon at the Texas Back Institute, but what you probably don't know is that in his previous life, he was a very high-level gymnast, an All-American gymnast, in fact, at the collegiate level at Stanford University. And with the run-up to the Summer Olympics in Paris coming up, we thought it'd be good to have him on and chat a little bit about not only his former life, but how that relates to his current life as a spine surgeon. So, Peter, good to have you on again.
Thanks for having me. Always good to hang out with you guys.
Awesome. Yeah, and a lot of us don't grow up sort of with your background and diving into the gymnast sort of activities, but we do watch a lot of it, especially as we come near this time of year. And sort of we look at the positions that the gymnasts are in and sort of the risks they seem to be taking in a lot of their activities, and a lot of the individual events. We sort of cringe at what could happen sometimes if they don't land a specific routine or a specific move. And we can only imagine that the training must be fairly rigorous as well. So I guess tell us about some of your early training, your early days in the sport, and some of the injuries that you faced or are most common in this population, and how you sort of work to prevent and recover.
Yeah, for sure. So I started gymnastics when I was 5 and went all the way through college, so 17 years.
Wow.
And most high-level gymnasts start at a very early age. If you're 7 years old or older, you're probably never, and you're just starting gymnastics, you're probably never going to get to a high level. And there's something you learn very early on, like air awareness is, I think, a big part of it. But one of the first things that you're taught as a gymnast is how to fall. And there's technique around falling because you're flying through the air and there is a lot of, room for injury. But even if you know how to fall, there's still obviously the chance of injury. Fortunately, there's not a ton of catastrophic type injuries in gymnastics, but those are the ones that worry people the most, right? So if we kind of go through the categories of injuries, and this is going to be kind of tailored toward gymnastics, but applicable to really any sports or any activity. The one that people are the most scared of, the most terrible thing is some sort of catastrophic fracture, breaking your back or specifically breaking your neck. And the reason that obviously is particularly scary is because the nerves and particularly the spinal cord in your neck, the spinal cord is the main highway that your nerves go down. And so you break your neck and sever your spinal cord or damage your spinal cord, that can result in paralysis or other kind of neurologic injuries. Now, fortunately, like that is not something that happens with any frequency in gymnastics, but that fear is out there. When I was a gymnast, my coach, when he was a gymnast, had broken his neck and required surgery.
Mm.
One of my teammates had broken his neck and required surgery, and another one of my teammates had broken his back. Fortunately, none of them had any sort of neurologic issues. So, they still were intact. They weren't paralyzed or anything like that. But it really puts things in perspective. This is a sport where athletes are flying through the air and wearing no protective equipment whatsoever. So I guess now that I know 3 of them, maybe it's not that rare that
Yeah. I thought you
having
said
these
this is
I was
injuries.
super
just
rare.
about,
Yeah,
yeah, I was just about to say that same
not
thing.
rare
Does
at
not seem
all.
rare whatsoever.
I'm gonna pull my kids from gymnastics after this. Um, so that's the one that scares people, but it's probably not the most common. Probably the most common for gymnasts and the general population of athletes and humans in general are like strains or sprains, so soft tissue injuries. Just like there are muscles and tendons and ligaments in your shoulders and your knees and your hips, obviously we have those things around the neck and the low back. And you can do things to sprain or strain or irritate, pull those muscles. And that can cause a lot of pain, cause a lot of flares of pain. Just like, if you're running, you can pull your hamstring, you can strain the muscles around your spine. And that can take a while, weeks to even months to improve. It's kind of like whiplash, very similar type of injury. So that's, we talked about acute trauma. We talked about muscle tendon type stuff. Stress fractures is another type thing. So we talked about, the acute fractures. You fall on your head, you break your neck, but stress fractures exist too, and actually are pretty common in gymnasts. there's something called the pars, which is a piece of bone that connects, basically, it's like it helps connect one bone to the bone below it in the spine and prevent the bones from sliding forward. And at the very bottom of the low back, at specifically the L5S1 level and the L5 pars, that level, it's like right down near your low back. And very classically, any sport that involves a lot of extension, so leaning back of your spine, which you can think, obviously, in gymnastics, you're doing kind of back handsprings and things like that. But other sports too, football linemen are the other kind of category of athletes that get these, because they're constantly getting kind of smashed into in an extended position. And what that does is it's like wiggling a paperclip. And over time, you can wiggle it and bend it and bend it and bend it, and then it breaks. And so when this pars breaks, sometimes athletes will have, some pain, but a lot of times they won't even notice it until years later. And what happens over time in some of these patients is that stress fracture kind of cuts the brakes of the bones, preventing the bones from moving forward. And so what will happen is usually the L5 bone will move forward on the S1 bone, which causes what we call spondylolisthesis, slipping of the bones. And that can result in back pain. It can also eventually, often when patients get to, say, their 40s or 50s or beyond, starts to pinch the nerves and they start getting sciatica down their legs. So, it's an injury that happens early on when athletes are, usually in their adolescence or teens, but usually doesn't manifest until later on. Although pars fractures can be painful. So there are patients who, are actively training at a high level who do have back pain associated with those pars fractures.
So I have a question for you. So you are now someone who's, I think, approaching 40s or close to 40s. I had heard a statistic back in the day, and I still tell people this, that I think that in high level gymnasts, that the rate of pars fractures is actually pretty darn high.
Yeah.
So do you actually know anyone from back in the day that has had this injury and is dealing with the consequences now, I guess, in their early middle ages?
Without a doubt. So two on my team from college come to mind. One of whom did not know he had a pars fracture back in the day, but is now in his kind of early to mid 40s and has started to develop those exact things. So back pain and sciatica. And then another one of my teammates, he actually had, I don't know when he had the pars fracture, but he had spondylolisthesis even as an athlete when we were in our late teens and early 20s. So his bone has actually slid forward and you could see it. So he must have had a relatively high grade. It had slid pretty far, because if you looked at his back, you could actually see the step off at the base of his spine. Neither of them have had surgery on it yet. Hopefully they can avoid it altogether. But it is very common. And for all I know, I'm walking around with it too. I've never x-rayed my back.
But it also goes to show like what we can actually accomplish and continue to do with some of the pathology we have. So we always tell people, hey, make sure you look out for these symptoms because you don't want to have this injury and let it progress over time. But as athletes at multiple levels, you're just sort of trained to push through, right? So like, is this just another muscle strain, or is it truly a fracture that's starting to slip? I guess one question I have is, obviously it changes with each stage of the level of competition and your activity, but what types of focuses are there in terms of like the prevention of those injuries? You mentioned sort of knowing where you are in space and learning to fall, but are there like specific focuses or regimens that are like, okay, hey, this is one area of your body we know you are at risk for even smaller or larger injuries? How do we go about trying to protect that region even more? And then when those injuries happen, what does the initial recovery process or diagnosis process look like?
Yes, definitely. So learning how to fall, that helps for the acute traumatic stuff, hopefully. The preventative stuff for kind of the repetitive overuse type injuries, that's all about core strengthening, especially for the low back. And in gymnastics, we spend a huge amount of time doing core strengthening type stuff. And when I talk about core, many patients think, oh, abs, right? That's the first thing that you think about. I got to do a bunch of crunches, which is actually probably not the most important thing to do, and maybe is even bad for you, right? Like if you think about what crunches are, your discs are in the front of the spine and you're just crunching and kind of compressing those discs. So I think that actually more important than crunches are things like planks, side planks, reverse bridges, isometric type activities. That's what we spend a lot of time doing, which builds those muscles, not just your abs, but your obliques in the side and your paraspinal muscles in your back, with while not moving, right? And so you're not putting yourself through these repetitive cycles, but you are strengthening your core to create what's essentially an internal back brace to hold you up and take the pressure off some of these structures and protect them when you're doing these kind of activities.
So now you're kind of on the other side of the patient doctor spectrum, right? So you probably undoubtedly dealt with numerous injuries in the past, that you had to work through and deal with, and perhaps you're even dealing with some of the sequelae of that these days. Although all of us are as we approach our 40s and whatnot. So in your life now as a spine surgeon, how do you take care of these athletes, especially the ones that are at a really high level that might have disc herniations, that might have even some of these more serious injuries like stress fractures? What are some of the treatments that we have available to take care of these athletes, and specifically focusing on some of the more minimally invasive techniques that we have?
Yeah, so the other and last category that we hadn't talked about was disc herniations, which I saved for last because that's really kind of my baby. For whatever reason, my whole life has built toward this career where I especially like taking care of disc herniations. And just for the audience, those of them who are not medical, between every bone in the spine, there's a disc. And the disc is a shock absorber. It's kind of like a rubbery type substance, and it helps absorb the shock of kind of life and also sports. And over time, in some people, you can get some wear and tear in those discs, and a piece of them can break off. And that's a disc herniation. And what that causes is pressure on the adjacent nerves and then sciatica down the leg. And similarly, you can have it in the neck that causes pain down the arm. So that's what a disc herniation is. And that's another big category of injuries for athletes. And interestingly, younger people tend to be the most common people that get disc herniations. And when I say younger, I mean people in their, say, 20s, 30s, 40s are the most common patients that I see and take care of with these things. As you get older, your discs kind of dry up and kind of degenerate so far that they don't tend to herniate as much. It's not impossible, but this is usually kind of a younger person's injury. And so the question becomes, how do you deal with these disc herniations? The good news is that the vast majority of disc herniations can be treated without surgery. So I'm a surgeon. We're all surgeons here. We love to do surgery, but my first choice and the least invasive option is still not an operation. And something like 80% of disc herniations will get better, and the pain will go away without an operation. But 20% of people, that's not the case. And if patients have exhausted things like physical therapy, non-narcotic medications, epidural steroid injections, and they still remain sufficiently limited, then thinking about surgery makes sense. The other kind of category of people that kind of skip that line and don't do as much of that non-surgical care are people with disc herniations and associated substantial weakness frequently. So, we call it a foot drop. So if you have a disc herniation and you can't bring your toes up, that's called a foot drop. And if you have a lot of weakness, then you kind of skip the line a little bit and progress to surgery more quickly, because that might indicate that there's some nerve damage. There are some like red flag situations, something called Cauda-Equina syndrome, like a massive disc herniation that causes complete obliteration of the area for the nerves and can cause numbness in the groin, difficulty with going to the bathroom. Like, that's an absolute emergency, but fortunately that's actually very, very rare. But for the run-of-the-mill disc herniation that's causing sciatica, pain, maybe numbness and tingling, but none of those more concerning things, including weakness, we try to get people through, and feeling better without surgery, and many people we can. However, if they can't, then you're thinking about, hey, is there an operation that stands to get someone better? And the answer is yes. Disc herniation surgery is very successful surgery, and selfishly, probably why I specialize in it, right? We get to take care of healthy, active people who are suddenly sidelined by an injury, and then in an hour, I can just make them better. And I'm just a simple guy that likes high fives and instant gratification, and that's usually what you get with this. Now, the traditional surgery for this is called a microdiscectomy, which works well. It makes people's sciatica go away. but it's not really the state of the art. It involves an open incision and burning and stripping the muscles off the side of the spine. And then the surgeon has to remove a little bit of bone, sometimes a little bit of the adjacent joint, just to get down and see the disc herniation. And it's not removing it that's the problem. Removing that piece that's come out is the solution to the problem, but it's getting there and all of the damage and collateral damage that's done getting there. That's the problem with the traditional way of doing this and the traditional way of doing spine surgery in general. There are some more advanced techniques. There's something called minimally invasive tubular retractors that allow for open surgery through a smaller and more friendly incision to the surrounding tissues. And then what I'm the most passionate about is something called endoscopic spine surgery, which is a complete kind of paradigm shift and departure from the way that this has been done previously. So previously it was just about like smaller incision, smaller incision, smaller incision, but still kind of fundamentally the same open type surgery. What the endoscope is a camera. And so rather than making an incision that I have to peer down into with my eyeballs to remove the disc herniation, I place a camera down, which allows me to use only like a dime-sized 8 mm incision. Camera goes down just between the muscle fibers, so you're not disrupting all those important muscle fibers and stabilizing structures. And then I watch the whole thing on a big screen rather than looking into the patient. And the camera is so small that usually I can get in to the spinal canal where the nerves are and the disc herniation is without removing any bone whatsoever. So in my mind, I think about it kind of like stealth surgery. It's almost like I'm cheating. Like I sneak in, I can sneak all the way down to the disc herniation, remove the disc herniation, and get out of there. And as a result, the patients have very, very little surgical site discomfort, but they get dramatic improvement in their sciatica. These patients are home within a couple of hours of surgery. Many people just take Tylenol or even nothing at all. And a lot of them are back at work within a couple of days. Now, the interesting question, I'm going to interview myself. What about return to sport? That's a great question, Peter. Now, return to sport. So the great thing about these endoscopic techniques is, you're not destroying the muscle. And so patients theoretically are physically able to do really all of their normal activities essentially immediately. There is, I'm a little bit torn here. So what I'm going to tell you now might be different a year from now, and the data is evolving. But traditionally, we have restricted our patients for, say, a month or 6 weeks after disc herniation surgeries. And the reason for that, in my case, and I still do this, at least right now, is not because that they won't feel up to going back to sport or because, their muscles aren't there. The problem is when you have a disc herniation, you have a weak spot in the back of your disc. And when you have surgery to remove that disc herniation, you still have a weak spot in the back of the disc. And we don't really have an effective way yet of patching that hole. There are some strategies and technologies that have limitations and have not really caught on for those reasons, but we don't have a good way of patching that hole. Now, the body heals over that defect over time. But it probably takes about a month, 6 weeks to get some sort of healing tissue over that weak spot in the disc. And so my concern is not that my surgery has limited them from being able to do these things, but that they can herniate again because there's still that weak spot in the disc. And in some ways, I'm concerned because the endoscopic patients, don't have that feedback mechanism because they don't have a lot of back pain. So I still restrict them from doing heavy bending, lifting, twisting for 6 weeks, but I let them walk, elliptical, stationary bike as soon as they feel comfortable after surgery. And many people are doing this the day after surgery.
So you're really protecting them from themselves to a certain extent without that inhibition. Yeah,
that's right. Now, we are talking right now about doing a study comparing no limitations to yes limitations. There was a study by Carnegie back, I believe it was in the 90s, where they compared restricting patients after surgery and not restricting patients after surgery. And it was a good study. I mean, they randomized these people. So they, it was a very, well-designed study, and they found no difference in outcomes. But the difference there is back then they were doing open discectomies. And so my concern is those patients had a lot of back pain after surgery. And so maybe we're limiting themselves. And so the question is, with endoscopic techniques, if you don't have a lot of back pain, are you at more of a risk or not with activity restrictions? I think we're going to have a good answer to this, hopefully in the next couple of years. And what I'm really hoping is I'll be able to tell my athletes, hey, we can do this surgery on Friday and you can go back to training on Monday. But that's the exciting and fun thing about medicine and science, is that we're continually figuring out the answers to these questions.
Yeah, and that's part of the crazy part of our field too, where you can have a research study that was done really well, 20 to 30 years ago, but the way that we treat those patients is so different now that you almost can't apply those findings, right? Because the difference between no restrictions in an incision this big and no restriction in an incision this big, right? Of course, this patient is going to be self-restrictive.
Right.
But
and yet on top of that, just the differences in disc herniations too, right? Where the location of the disc herniation is, how big the hole in the back of the disc is. There are all these factors, in addition to the differences in sport, right? The gymnast who puts a tremendous strain on their body, as opposed to, I guess I'm going to winter sports here, but curling, and not to put anything against the curlers, but definitely a different amount of strain on their and stress on their spine than the elite level gymnast, right?
Right. So, as I said, I let them go back to kind of low impact cardio type stuff. So at least they can keep their fitness going. And then once they get to that 6-week mark, I let them kind of go back to the more, intense activities and sport level training.
Yeah. I think this is certainly a very interesting evolving area for research, and is going to not only affect the high level elite athletes that we're going to be seeing here in Paris, but also our patients that we take care of every day, right? And so this is really, I think, a very timely topic. It's awesome to hear about all these ultra minimally invasive techniques that can be utilized for conditions like disc herniations. And as time goes on, I think we'll even see these ultra minimally invasive techniques be utilized for other types of pathology that maybe are not utilized right now. And then I think it's also important to remember that the key thing is that we apply, as surgeons, the technique to the type of pathology. Not everything can be treated by an endoscope, but I think one topic we're not going to touch on now, but the thoracic disc herniation, some of the really scary types of pathology, that traditionally required even bigger approaches. If that can be treated endoscopically, it turns what's a pretty scary operation with a big risk just from the approach into something really small and outpatient, which is pretty cool.
And similarly, the neck. So this is relevant to athletes. People who have a disc herniation in the neck often end up with either a fusion from the front or a disc replacement from the front. Those are the two most common options, at least in the United States. And I've taken care of a couple of impact athletes, a high level martial arts competitor, and then also an MMA fighter who had disc herniations in their neck. Young people usually would get a disc replacement, but were worried about having a prosthetic device in their head that's constantly getting kind of pummeled back and forth. And so they were both referred to me by other surgeons who had concerns about, even doing a disc replacement in someone like this. And I did an endoscopic, it's called posterior cervical foraminotomy and discectomy, similar surgery that we talked about in the low back, but in the neck, which allows, access to the disc herniation, removing the pressure from the nerves in the neck without putting a prosthetic device in there. And so the patient still has their own parts and are still stable and return to those high level activities.
Cool. Yeah, that's awesome. It's sort of fun to hear your life evolve in this conversation as to sort of where you started and where you are now. And that's such a great story. Thanks so much for joining us today. It's always great to catch up with you. I'm itching to go do some core exercises right now because you've inspired us again. Vandy can go back to doing his crunches because I think that's what he enjoys the most. But no, thank you for your time.
I'll switch from my Kegels that I've been doing during this video.
Oh, good. Yeah, you look great.
Well, thank you for having me, guys.
Yeah. Yeah. We'll have to have you on again. I mean, it's always so much fun to talk with you, and thanks for sharing your knowledge and experience with us today.
Have a
So
great
for everyone
day.
else, yeah, thanks for joining us. Don't
Thanks,
forget
man.
to like and subscribe and follow us on Instagram at the Athlete Spine. Have a good one.